research to find a cure for cancer, which we'll learn more about, throughout the discussion here today. But she earned a doctorate as well in epidemiology, health psychology, and biostatistics from Harvard University. So you can see what I mean. Kate is absolutely the Michael Jordan of digital health. It's going to be such a fun conversation today. Kate, thanks again for joining us.
Thank you for having me. You as an entrepreneur know that things don't always go according to plan in entrepreneurship, and things can often go quite different from how you expected. And every time that something does not go according to plan, my husband sends me the Michael Jordan Nike video where he talks about how many times he's taken the game-winning shot and missed.
Nice.
But he has never once compared me to Michael Jordan. And I think if asked, he's more likely to compare me to Dennis Rodman. So I'm going to just stick your analogy in my back pocket and hold on to that.
That's great. That's great. I love it. So it fits. I think it fits. It qualifies since your husband gives you the Michael Jordan quote.
All the time.
I had neglected to toggle through a couple slides here. I apologize. But I'm going to land on this one just for a second before we get into the conversation. So here's our agenda for today. We're going to cover 4 primary topics. You can see them on the screen. The first topic touches, more so on population health and its relationship with digital solutions. Second topic will go into behavioral science and its overlap with digital solutions as well. We'll land on the future of personalized care, and Kate's got some great examples in that area, obviously. And then we'll also touch on how personalization plays a role in designing effective behavior change solutions. So that's the agenda for today. One more quick slide that the chat is open. So please say hello. I see we've got a few chats already out there. Thank you for posting. Say hello. Let us know your name, where you are. Ask any questions throughout the conversation. We will reference them throughout and also circle back on them at the very end of the conversation. So look forward to your participation, and that brings us to a conclusion on the slides. Let's go ahead and dive in, Kate.
Sounds good.
So Kate, if you wouldn't mind, I'm still on the topic of population health. Many of us in the audience, I'm sure, have heard the phrase population health before, but may not have an intimate understanding of what population health exactly means. Would you mind just giving us a broad overview of what the definition of population health is, and then as an example for you, what specifically attracts you to population health? What excites you about it?
Oh, such a good question. So I tend to think of it as like medicine, right? Is when I go into my doctor's office and, we're talking about what's happening with me specifically and why I might be feeling a certain way, what risk factors I might have for a condition. And that set of risk factors comes from us studying populations and looking at what statistically makes people more likely to sort of develop a condition or not. And so this really started back in the day when we didn't have clean water supplies. We actually had a community pump, and looking at the spread of certain illnesses in London. And John Snow, who's the sort of godfather of population health, noticing that their distribution was different in one community versus another, and that there was this one individual in the community surrounded by people who were getting ill, and she was not. And in the conversation, realized that she believed the water tasted better coming from a different well. So her household staff was walking over to a different well to get her water. And so that led him to take the handle off the community well to see if they could stop the spread of the infection, right? So rather than looking at the individual patient who is coming in, right, coughing and sick, looking at why a group of people might be more likely to be coming in coughing and sick. And so we've extended that over time from infectious diseases to looking at chronic diseases. So I think most of us are sort of very familiar with the Surgeon General's reports that came out in the 60s, which allowed us to determine that people who smoked were more likely to develop lung cancer. And we've continued to use those tools over and over again. And so for me, the appeal in that was really that those tools are often used to think about how we might prevent diseases instead of treating them. And that really appealed to me as a undergrad and as a potential graduate student in graduate school, was looking at how we can help prevent people from getting sick, not just treat them after they're already sick.
That's so interesting. I love the story about the water pump in London. And Kate, like as you're talking about it, like what pops into my mind is the triple aim of healthcare. And for those on the audience that aren't as familiar with it, the triple aim of healthcare is the highest quality, one, at the lowest cost, two, and three, providing overarching access to as many people as possible. So the triple aim, what struck me about, your response to population health is that, and I think this is just counterintuitive, so to speak. Like the current U.S. healthcare system just seems unsustainable if we're just going to keep treating symptoms on the back end, right? And we're seeing symptoms like as a healthcare system already, like evidence of this, right? Like there's nursing shortages, there's caregiver shortages, costs in the US are higher than any other developed nation. Our access is actually lower than any developed nation. We're at like 90%.
And unevenly distributed.
Yeah, isn't that? Yeah, it's so interesting. And so when you say preventative health and population health, or related to population health, to me, and I know we're going to dive into some of this more as we go through the conversation, but it's like, if we can find ways to better take care of ourselves and each other and prevent these illnesses, the overall health system is gonna benefit from it, right?
Right. And I think the thing that's really important about population health is it's not about just what the individual is doing. So like if I use smoking cessation as an example, right? We certainly can do educational programs to help people understand the harms that come from using tobacco and smoking cigarettes. But the biggest impact we had on smoking rates in this country did not come from educational interventions, right? It didn't come from those tools. It came at the policy level. So two key policy changes. One was our utilization of taxes, which functionally raised the cost for the average individual to smoke. The much bigger impact, in my opinion, came from our change of policies in where people could smoke. So we implemented smoke-free bars and restaurants and smoke-free workplaces. We changed the context that people lived and worked in, right? So that you weren't surrounded by people who were smoking. We made it harder for people to smoke, right? They had to go outside. And we changed the social norms around smoking behavior. And so that had a far greater impact than all of these. I mean, the ad campaigns were great, right? Like everyone remembers the Truth campaign where they piled the body bags up in front of Philip Morris in New York, right? Like really memorable, like shows the value of health communication for sure. But when you really look at where the impact in smoking rates started to change, it was with those policy changes. And so I think that's the interesting part about population health is that it's not about identifying at a population level what's happening and then pushing individuals to change. It's also about changing what happens for populations.
That is so interesting. And I want to circle back on that a little bit, the policy aspect, Kate. Like, given today's political environment, I mean, what are your current thoughts? I mean, do you have any? I mean, can policy continue to help? Like, will it continue to help?
Yes, absolutely. And I think part of that is, my mother used to tell me all the time, right, that a lot of the most important things that happen in policy do not happen at the national level, right? They happen in our communities. And that was the case. Smoke-free bars and restaurants did not happen nationwide. It happened community by community. So cool. I was in Massachusetts for undergrad and grad school, and right, like one community, one town in Massachusetts implemented that. And the fear from all of the bar and restaurant owners was that they were going to go out of business because everyone was going to go to the town next door and go there instead. And now, sure, some people did, but a whole lot of people started coming to that town because as non-smokers, they loved not having to sit like in a smoky bar restaurant, right? Like it was better. And it was better for the employees because all of these people didn't want to work in a smoky bar or restaurant. So you had greater access to talent, right? Like, so it's really interesting to think about how that happens in one community and it spreads from there to the town, to the next town, to the next town. It builds the political capital and the political will to do things. So things don't have to happen in Washington, D.C. to have an effect, right? Like now, certainly I'd love to have a whole conversation someday about what our farm policy does and how we make, certain foods that aren't particularly healthy, cheap and easy to access by underwriting their cost at a farm policy level. Do I think that's going to change anytime soon, Michael? No, I don't. But there's a lot of things that happen at a very local level that have an enormous impact.
Well, that's great. That's encouraging.
Yeah.
Right? I mean,
reason to be optimistic.
Exactly. Maybe we can get more done at the local level than the federal level.
And reasons to look in places like the Midwest for interesting things that are happening.
Exactly.
Because everything doesn't happen in New York and San Francisco.
Great point. Kate, I wanted to touch on too, just kind of reading some of the research that you were doing prior to starting your entrepreneurial career, particularly your cancer research. And I know I said curing cancer, and I think that's
ambitious, bold.
And that's the phrase that we use today in society, right? Like cure cancer. But like, interestingly enough, when tying back to the population health conversation, that kind of implies that like someone gets cancer and then we treat the symptoms of it, where a lot of your research was based more on, hey, actually, there's a lot that we can do on the front end to prevent ourselves, or at least significantly reduce the risk of developing cancer.
Yep.
Could you touch a little bit more on just that research a little bit, and what you learned from it, like what some of the most significant learnings, and maybe, I don't know if there were any challenges or coming out of it, if there were any challenges that you see as we pursue further research in that area going forward?
Yeah, it's one of my favorite topics. When I finished my postdoc at Northwestern and I was trying to decide where to go next, I ended up going to WashU in St. Louis. And one of the things that drew me there was the head of the cancer center was going to be my boss. Said his goal was to put himself out of a job, right? That we've done such a great job of preventing cancer that no one needs to come see him for treatment. And I love that vision. I think one of the things that surprises most people is that the majority of cancers are preventable. Very few cancers are 100% purely genetic, less than 5%. The rest are a combination of genetics and something else, right? So the phrase we use in cancer epidemiology is environment. And I am always hesitant to use that in these conversations because people think, what's the movie that Julia Roberts plays the woman?
Erin Brockovich.
Yeah. So like they think environment like pollutants,
but
like when I mean environment, I mean a broader set of lifestyle and contextual things that are happening. So depending on the person's math, like 50 to 80% of cancers may be preventable, which is what we've learned through population health. And so those are around things like smoking, sun health behaviors, right? So use of sunscreen, wear a hat, seek shade. So like that sun protection, reducing our risk of infection, right? So HPV and cervical cancer, hepatitis is related to liver cancer. So when we prevent those infections, we actually are preventing cancer. So those are the ones that people don't know about as much. But then we have the ones that they're the unsexy things, right? Like maintaining a healthy weight, eating a healthy diet, being physically active, right? Like those are things like, I remember someone saying like, oh, could you write an article about like how to prevent cancer? And I was like, sure. Like, here are the 8 things, right? And they were like, yeah, like that's not interesting. And I was like, well, it's true, right? Yeah. And I think sometimes it gets like really complicated, right? Like I did a lot of research in physical activity, both in preventing cancer, but also in improving outcomes after diagnosis. So allowing people to live longer and live better after a cancer diagnosis, it's important as well. And, I would go talk in the community and people would be like, Kate, I don't like to run. And I was like, who said run? Right? Like I said, be active.
Yeah.
And so I think, that sometimes we have a tendency to make things interesting and fresh and headline making, right? That we make them more complicated than we need to, right? Like eating fruits and vegetables, good, right? Like better than eating M&Ms, Cheetos, and Ben and Jerry's, much as I like all of those things. And so, it's like, rather than getting lost in the weeds of whether like the value of acai berries, like how about like have an apple, right? And so like, and the reality is most people in this country eat almost no fruits and vegetables, are not physically active at all. So it's, it's not about running a marathon or doing nothing. There's this whole range in between. And doing something is better than doing nothing. And so like, yes, right. Part of what we did, in our research was actually to try and answer this question, because the question I would always get is, how little exercise do I have to do to not get sick, right? And I get it, like we're busy, right? We have competing priorities, and that's important to understand. But like that was, to me, always the interesting thing is like, I'm not saying you have to go run a marathon. I'm not saying you have to go run, right? Like if what you like to do is, to crank up like, that awesome 80s, like hair metal playlist on Spotify and like dance around the kitchen, like cool, like great, like if you can get 30 minutes of activity between that and a couple other things, like fantastic from a cardiovascular disease prevention perspective, from a diabetes prevention perspective, from a cancer prevention perspective. And I think like that's the great thing too about these lifestyle behaviors is the bang for your buck, right? Like exercise is not just related to cancer risk. It's related to a whole bunch of chronic diseases. And like people who are active tend to report feeling better, which is, another thing we'd all like to do and feel.
Yeah.
So, I think that's the thing that I love about those lifestyle behaviors is that you're actually having a system-wide effect. And so, like, yes, like it's great that we have medical research to find medications. And that's been really powerful as well. But we also have these other tools that, unfortunately, it turns out people keep telling me that talking about broccoli is not sexy.
Well, this is like you mentioned behaviors, Kate, and it's a perfect segue into our next topic. And before we jump to it, just to kind of recap what we touched on in the population health section. So we touched on like, I'm kind of summarizing it as like 3 key takeaways. One is like preventative care rather than treating symptoms on the back end is really important for us as individuals, but also for population health, right? Like the system can't continue to treat everything on the back end. And then you mentioned policy, and not necessarily the federal level, but the local level actually can have just as much, if not significantly more impact than the federal level. And then regarding the cancer research, right? You said less than 5% of it is genetic, and I think
purely genetic. Everything else is mostly a combination.
So interesting. So, and that provides that perfect segue into, I think, behavioral science. And it's interesting because like our conversation almost parallels your career to a certain extent, because you went from research to entrepreneur. So we're kind of like following that similar track, but for those, and I know there sometimes is some confusion regarding behavioral science versus behavioral health. Yeah. Would you mind defining behavioral science for everybody on the call, just so we all have that baseline before we kind of dive a little bit deeper?
Yeah. So like when we do it, right, it's really understanding human behavior and what drives behavior and what we can do to support behavior change or encourage behavior change. Whereas, behavioral health is typically used sometimes interchangeably with things around mental health and mental health care and treatment. And I think we use behavioral health to reflect a broader spectrum, right? That people may have symptoms or similar indications right before a diagnosis of a mental health condition. And so we're trying to cover, similarly like population health, right? We want to cover that whole spectrum of care before a diagnosis and illness in behavioral and mental health. In behavioral science, we're talking about all kinds of behavior changes. So I focus on health behavioral science, but there's also, people who focus on, behavioral science around climate and recycling, people who focus around behavioral science around financial well-being and financial health, right? How do we use behavioral science techniques to get us to save more and spend less? So there's lots of contexts that behavioral science is used in. It's sometimes also used for evil. It's not always used for good, right? So people use it to try and get us to spend money we don't have or to engage in behaviors that aren't healthy. And so my focus is on doing that. And I do it in my career really in outside of a tight lab setting. So my research when I was in academia was in clinics, in workplaces, in community health settings, in the home, versus sort of terrible reference, like what you might remember from Ghostbusters, where you're bringing a bunch of graduate students into a lab and trying to manipulate behavior in a tightly controlled environment. The way we do it is much more in the context that people live and work.
Interesting. And Kate, you could you tell us a little bit more about how you transitioned from researcher to entrepreneur? Like just what prompted you to kind of make that leap?
So as I said, like my research really was in these other settings and I did a lot of work in health disparities and understanding those contextual factors that lead to health disparities. And as a result of that was doing a lot of, how do we help patients who might be coming to our cancer center from, hours away. And, we need to be able to support them after they go home for treatment. How do we help them prepare for treatment to be successful? And so started using a lot more digital strategies as part of that. And that led me to ask questions around, what is it like for someone who lives 30 minutes from our cancer center, 3 minutes from our cancer center versus 3 hours from our cancer center? Do the same interventions work? And do they work equally well? Because the context can be really different, right? I mean, many of our cancer centers 3 hours away, or many of our cancer centers are in urban environments, and you go 3 hours away, and it can be quite a rural setting. And, that's true for us here in Chicago. It was true for me in St. Louis. I grew up in central New York, which is a little more than 3 hours from some of the major academic cancer centers. But, the same is true that, when I'm talking to people about being physically active and they live in Chicago, we're talking about sidewalks. We're talking about using public transportation and getting off the bus a stop early to get a little bit more activity in. And when you're talking to someone who lives in a rural area, right, you're talking about not getting run over by a tractor trailer coming down your country road when you're out for a walk because there is no sidewalk and you'll end up in a ditch, right? So understanding the context that people live in is really important for behavior change. And how do we create programs that help people regardless of where they live? And that to me was this really interesting question. And academic research is amazing and so important for scientific discovery, but is really focused on discovery and not real world implementation. And I realized what really excited me was asking these questions about what does this look like in the real world? So as I leaned into some of those, my dear friend and colleague had just finished a clinical trial in his lab of 100% digital weight management intervention. And he said, I think this is the kind of thing that you're talking about where, it could work for people in all kinds of settings. And it's really light touch. So it can work for people of lots of different economic positions. And like, could you give me your view? And I was like, I totally agree. This could be an amazing product in the real world. And that led to our team working on it sort of nights and weekends. And then it kind of got to a place where someone had to run that business full time. And That was me. I was really,
That's awesome.
yeah. So like, I was really excited by what that could mean and what that would look like.
And that was scale down, Kate?
And that was scaled down. Yeah. And I think, I also like shout out to Chicago. Like I had gone back and learned to code as part of that move into digital at what was called the Starter League, which was the first coding boot camp in America here in Chicago. And like that community of people who really pushed my thinking around like all of the things that we do in user-centered design, right? And understanding your customer, and then all of the entrepreneurship things around what's the business model and who's willing to pay for that. And so like, through Starter League, really got exposed to a whole bunch of people who pushed my thinking around what makes for a successful, not just like an intervention in academia, but a successful solution in the real world. And so like that was really important part of that journey as well. And then like I have the world's greatest spouse who said like, stop talking about it and like, get off the bench and go do it. And without that, like I probably would have sat and like perseverated and analyzed as scientists are wont to do. But that community and that person really made it a little less scary to take the leap.
Neat. Could you mention the I think you said, did you mention the Chicago Starter League? Is that
Yeah.
Okay.
Yeah.
And you're talking about the business model or helping form a business model around scale down. Could we dive into that a little bit? I think that would be so interesting for us to learn about. So for those of you, so I'm going to like use the business model canvas as a framework. So, those of you that are on the call that are familiar with it, I'm starting in the center with the value prop and the far right, like the target customer segments.
Yep.
How did you define the value prop at scale down, Kate? And who was your target customer base? Just as like a starter for product market fit, how did you establish that?
Yeah. So what we really focused on from a value proposition perspective is that we know self-monitoring is a really important part of supporting behavior change, particularly in weight loss, but in a lot of places. And we knew that people don't really stick with self-monitoring, right? Like I mean, good golly, all of us have the drawer of fitness wearables. Like I call it my graveyard. So yeah, I get the wearable. I wear it for a little bit. It tells me that I got 10,000 steps today. Within a pretty short period of time, like I have a sense of whether I'm hitting 10,000 steps today or not, right? Like maybe not exactly, but like, our lives have a pattern to them for the most part. And you get pretty clear, right? Like that on the day I go to the gym for 30 minutes and I get off the bus to stop early and, I walk the dog, like I'm pretty close to my 10,000 steps. But if my routine changes and I have a meeting somewhere and I don't take the bus, like I've got to compensate, right? And so the value that wearable provides decreases over time because I'm actually creating the insights for myself, right? Like I'm having to talk myself through the strategy and the plan, right? Okay. When I don't take the bus, I've got to do something else. What's my plan for that? That is a behavior change technique, right? That is action planning. And the wearables by themselves don't give people those action plans. Okay. So the value prop for us was, how do you make self-monitoring easier so that people can comply? And how do you deliver the behavior change techniques and insights to people in response to the self-monitoring to, one, create a reinforcing mechanism, and two, right, like which should drive adherence, engagement, and clinical outcomes from a scientific perspective. So that was really like what we wanted to do, was to sort of give people a sense that they were doing the right thing and making progress, to take away those things that tend to lead people to disengage from that desired behavior.
Gotcha. So interesting. And the target market, Kate, like how did you?
Oh, I wish I could tell you that I knew what I was doing.
Okay.
Right. But like, I mean, let's pull back the curtain, right? Like there's a test and learn that comes with being an entrepreneur, and we make a guess. And as I said, like
Yeah.
Sometimes you take the game-winning shot and you miss. So what I knew is that I did, if you go back into your Wayback Machine into 2013, 2014, other iconic Chicagoan, Ms. Oprah Winfrey, had just invested in Weight Watchers and was their spokesperson and was doing all of these ads all over national television. I am not Oprah Winfrey, and I do not have that kind of marketing budget. So direct to consumer felt off the table to me. And so then sort of when you think about like a B2B option, right? Like there's a couple places you could go. I think those of us who work in healthcare tend to know this, but I've also met people who work in healthcare who don't, that a ton of what happens in healthcare, particularly in population health and prevention, is driven by the self-insured employer, right? Because they are who insures most, the majority of working Americans, other than those who are on Medicaid and Medicare. And so they have a huge influence on prevention programs in the United States. Medicaid and Medicare have more in the secondary prevention, tend to be less in sort of primary prevention realms. But that was certainly another avenue. I could go sell to providers, and the challenge, of course, and that is most of us are in a fee-for-service model. And so how is a provider going to make money in this? And then out of left field comes this other B2B customer for me, which was a pharmaceutical company. They were bringing a new weight loss drug to market, and their market research had shown that physicians didn't want to just prescribe a drug for patients. They wanted patients to be in a comprehensive program that included medication and behavior change.
Okay.
Rightly so. And so they also had a goal of bringing people into the weight loss drug market as prescribers who had not historically been there. And that meant those people were unlikely to have a behavior change program in their back pocket. So if you're a physician at a weight management clinic, you probably have a staff who can deliver a behavior change program to the patient on that drug. But if you're a primary care physician, you may not. Okay. And so if you are that pharmaceutical company and you want to open up a new market, right, from our business model perspective and bring new prescribers in, and those prescribers need drug and behavior change program, you're going to be more successful if you come with a drug and a behavior change program. So we were fortunate to be invited to be considered to be their behavior change program partner. And the team loved our user experience. We worked really hard to take a lot of friction out of the user experience. So my favorite example is that our scale was a cellular connected scale, not a Bluetooth or Wi-Fi scale. So people who were early adopters of the Kindle will remember that the first generation Kindle connected through cellular technology because a lot of people didn't have at-home Wi-Fi at the time. And so we used that same cellular technology in our scale. And that meant folks did not have to have a smartphone. You could still be rocking the flip phone, which I'm told is like hip again in like certain communities.
Really?
The young people, not my generation. Right? They're trying to be less addicted to their phones, so they're going old school, getting back to the flip phone. But you didn't have to have a flip phone. For folks who were less tech savvy, you didn't have to do device pairing. Right? The scale arrived, you took it out of the box, you stepped on it and got a text message from us because we paired it to your account at the warehouse before we shipped it. So like there were elements of that, like to go back to value proposition and sort of the four forces, which folks may be less, right? But there are things that pull you to a new solution and there are things that pull you away, right? Inertia, things that are hard behaviors to change. And so we actually both had things that pulled people to our solution, but also thought about what would likely be barriers to using or sticking with the solution and how do we take those out of the equation. So we won that contract, I think, because we had thought about both of those things. And we're super nerds. So we had a clinical trial that showed our solution worked. And that matters to pharma, right? It matters to them in a way that maybe other customers, particularly at the time, it didn't matter to.
So it's a combination of the research and the user-centered experience design
Yeah.
was like, okay, great. And then segueing from like behavioral science into like the personalization aspect, Kate,
Yeah.
could you kind of unwrap that a little bit for us? Like what did that personalization feel like to one of the users of Scale Down?
Yeah. So I think, there's two parts to it. One is like, you and I both know that like a donut is probably not the healthiest breakfast choice. We also know that sometimes you and I, like, nothing goes right in your morning and you walk into the conference room and like someone brought donuts and like, you're like, oh, yeah, today's my day.
Best.
Right. And so, what we're trying to do is move beyond just sort of telling people like, donuts aren't a healthy choice, try oatmeal, right? But to think about these behavior change strategies and techniques, and how do you pair those up in a way that resonates with people? So if you tell me that like donuts are your jam, right, then what I'm going to do is to give you some strategies for if you're going to, say, a conference and there's likely to be donuts right at the morning coffee because they want people to network and mingle, right? Have a plan for how you're going to navigate that, right? And your plan might be, I'm going to limit myself to a half a donut and I'm going to eat healthy the rest of the day so that I can enjoy that donut. Your strategy might be you're going to eat like a different breakfast before you get there so you're not hungry, right? Like there's different ways, but part of that is teaching people that action planning part, not just telling them like donuts aren't healthy. And so that action planning behavior change technique is more likely to stick with you if the example I use in the action planning technique is one that's relevant, right? So if I use an example of donuts and you are not a sweets person, you're kind of like, and you miss the action planning part because you're like, I don't like donuts. But if you've told me that like, salty snacks in the evening is your jam, right? Then I might use an example about going to a work dinner or a reception, or you're going to a party. And right,
Okay.
there's all these different ways that we can try to make it relevant to you in our personalization strategy. So that's one part of how we personalized it.
Was that through like a survey, Kate, or something like that you did up front?
We did. So we it's the other part of that, like taking friction out, right? We pushed, I am an epidemiologist by training. I love a 300 item survey, so much data, right?
Yeah.
Like amazing. Who wants to complete a 300 item survey?
Right,
Not me, not you, right?
Mm-hmm.
So what we really pushed were like, what were the 10 things that I need to know on day one to drive personalization, and no more questions get asked.
Okay.
Right. And then
Right.
I earned the right to ask you more questions by delivering something of value to you. And so if you are getting something from the program and you are seeing the value, when I ask you a follow-up question for more information, you are far more likely to respond, right? You trust me. I'm actually also then likely to be able to ask you questions that go a little bit deeper. And so I think of it really as like, it is very patient and user-centered. How do I earn the right for you to give me your information? Okay. So we ultimately grew the personalization grew over time based on what we learned from you, but also by asking you questions.
Gotcha.
Makes it much more complicated from a product perspective because now I'm more likely to have missing data and I have to figure out what to do with that. So made it really fun for nerdy little me. Right. We also then had the weight data from the scale. So that was obviously a key part of this, right? Are you gaining weight? Are you losing weight? Are you engaging? Are you not engaging? Are you trending in this direction or that on either of those metrics, right? So I can use that. Right. The other, like as an example, one of the other ways we use context and personalization is the weather. So rather than saying like, Michael, get your steps today by going for a walk, I might say to you, Michael, the weather forecast in Chicago today looks chilly. Make sure you have a plan for how you're going to get your activity in, right? Here's a link to some things you could do indoors.
That's cool. I appreciate you sharing the examples, Kate. And, this is kind of a funny story, but so how you and I were introduced, right, was through Joe Dwyer. And for those of you that don't know Joe is one of the 3 co-founders of Manifold Group. he's also on the faculty at Northwestern. I took Joe's entrepreneurship class several years ago, and one of the main project for the class was to create a startup with a small group. And our startup was based around medication adherence. We were going to build an app that, when it was time to take your medication, a picture of your grandson flashed up on your phone and said, "Grandpa or Grandma, don't forget to take your heart medication today." So it was pretty elementary, obviously, but there's aspects of personalization in there, right?
Absolutely, right. Making it relevant to the person. And that's a strategy that's been used in smoking cessation. And I think it is the other part of this, right, is remembering that our context changes. And so, that's also, sometimes in science, we tend to poo-poo things that make things enjoyable, delightful and fun, but those can be really important parts of engaging people, right? So I'm never going to get to preventing, a second heart attack if you don't use my solution, right? And so, yes, there's all of these important health information and all of those things, but right, like, to your point, right, like you start with like, here's a picture of your grandkids, right? Like future versions of that app could have an animation of you and your grandkids going on a walk together because you've taken the medication, right? You can do things together. And I think those things are important to remember, that if that makes it enjoyable, that's also valuable, right? Because like as humans, we are drawn to things that are enjoyable, and that matters as well.
That's interesting. And Kate, like behavioral science versus personalization, like it seems like there's some overlap between the two, or I don't know how significant it is or how significant you would describe it, but
it should be a lot, in my opinion. And I say that because there are close to 100 behavior change techniques. So the techniques that are most salient and relevant for me may not be the same that are most salient and relevant for you, even if we are both in a program to, help us manage our COPD, right? And like our contexts are different, our barriers are different, our motivators are different, and none of those things are consistent, right? So I might be going along great in this program, and then something happens, right? Like my job changes, my family situation changes. And now like a different set of behavior change techniques might be more important for me. And so to me, like one of the really important places that personalization can deliver value is by figuring out what is the right technique to use for you or for me right now. And they might be the same, right? Like in a lot of situations, there's an enormous amount of overlap. Like I'm not arguing that everything has to be done with AI and ML and you've got to spend millions of dollars to do it, right? Like decision trees work a lot of the time as well, right? It doesn't have to be super complicated, but there are these ways that we can make people feel like they aren't a cog in a machine. And that's one of the other interesting things about personalization is there's some data that suggests perceived personalization is more important than actual personalization, right? Like we want to believe that we are special and unique and not like anyone else. And sometimes we are, and sometimes we aren't. And, and I think the other risk is if you try to personalize and you get it wrong, you can lose user trust. So there's a risk to personalization as well.
Yeah, you lose the trust pretty quickly, I imagine, if you send a message that's out of context.
Yeah.
Wow. We've got a couple questions, Kate, here regarding diabetes prevention, and I know you've touched on the DPP in the past, right?
The diabetes prevention program. Yeah, so the diabetes prevention program really opened up the evidence space in digital health. So it was a really large-scale clinical trial conducted at a number of universities funded by the federal government through the National Institutes of Health. Yay, research, keep funding research. And The original DPP was done with like a notebook, like in a binder, right? Pieces of paper. And we got those who were enrolled in the intervention arm together on like a weekly or monthly basis for in-person group coaching. And the clinical trial of the DPP compared that behavioral coaching and behavior change intervention program with metformin, a drug, and usual care, the control arm. And the behavior change intervention was the most effective and the most cost effective of the arms in the trial. And so that was great. And we can do DPPs in hospitals and community health centers and community settings of different kinds. But, you know, what we also thought was like, can this be delivered not in person? And so a lot of innovation in digital health really started with taking this thing that works in a non-digital setting and thinking about how do we use technology to decrease the cost of delivery and increase the ability to scale and reach more people.
So interesting. And Kate, you touched on something I want to just dive into a little bit more too. Like, and you've touched on this a few times through the conversation, but just the relationship between academia or / research and entrepreneurs. I know you've touched on this in other conversations as well. Just how do we foster those relationships? Because for example, like I went to a healthcare event last summer with our head of marketing here at Manifold, Phyllis Lee, and one of the individuals that I met was at the NIH, was from the NIH. And it was a great conversation. He said, Mike, we're looking for entrepreneurs to partner up with all the time because we've got all this mounds of research that we've done that is credible and is real, and there's real value to it, but we can't take it to market. And we, you know, and that's not our specialty. Like building a business model around like this research isn't our specialty, and we've got patents and, you know, all this kind of stuff. So we're looking for teams to partner up with all the time. I mean, what's your take on that, Kate? And like, how do we foster more of that collaboration going forward?
Yes, more. I'm thrilled that you got to meet someone from the NIH and that was the message, because it's true. There is a lot that science can teach us. And when I work with companies, you know, what I always say is like, you don't have to start from ground zero, right? Like, if you're a stats person, right, we talk about Bayesian statistical models, right? We use the known priors to seed our model and grow from there. And that's how I think about digital health entrepreneurship. Is we've got decades of research into what is an effective behavior change strategy. That doesn't mean academic science has figured it all out and that all of the answers are in the published literature, but there's a ton that is of really high quality science that is out there that we can use to de-risk our assumptions, right? Like we always talk about entrepreneurship, our riskiest assumptions. We have all of these hypotheses that are underpinning our value proposition, our path to product market fit, our go-to-market strategy, right? What can we learn from that allows us to make decisions with more confidence, or to sort of say, okay, I've got 4 options and the science says this is unlikely to be the one. So I'm going to take that option off the table and I'm going to focus on these 3, right? Like that's a value driver from a business perspective, because it allows you to move faster and use your resources more efficiently. So it doesn't have to be as far as like, you know, walking into the medical school and saying, like going to tech transfer and saying, what IP do you have for me to work with, right? It can be really just engaging with scientists to understand and value what they know, which scientists love, right? Like they love to know that their science is valuable. And so that's, I think, one part of it. I think, you know, leveraging scientists to have conversations about what should we measure and how do we demonstrate our outcomes, right? Like, unfortunately, the reality is there's a bunch of snake oil in our realm. People who make claims that they can't support, people who manipulate data. Sometimes it ends up in a lawsuit. Sometimes, you know, they skate by. And, you know, when we engage with scientists as advisors and consultants, we can talk about, you know, what do we measure as leading and lagging indicators? how do we think about analyzing our data appropriately and analyzing, making sure we have the right amount of data in order to make meaningful and credible statements about the outcomes that we deliver. And I think, there's a company I love in digital health called Disrupt, and their whole value is around connecting startups to clinical and scientific experts. Because, if you're a seed stage company, you may not be ready to have a full-time behavioral scientist or a full-time chief medical officer, but that doesn't mean you can't have any clinical and scientific expertise. So how do we make sure that those people are at the table and that their expertise is being engaged and involved? I think on the flip side, far too often academics think like the DPP, we created this intervention, it is perfect, take it and go. And what they have not considered, to your question around scale down, is the business model, right? Who is going to pay for this and what is the value proposition, right? And in our conversation, we talked about the value proposition to the end user, but we also talked about what's the value proposition to my pharma partner.
Right.
And
right.
Understanding like that part of it, or, the friction and so many things in healthcare is around the workflow for physicians and other clinical staff, right? Like they're burdened, they're burned out, right? And so if your solution requires them to have a whole new workflow, like that's probably not going to go anywhere unless you've got, something that's going to overcome that. And so really, I think the academic side, recognizing that there are all of these other elements that take something from good science in a clinical trial into something that is usable, that someone will pay for outside of research.
That's so great. I can see a lot of value there. And basically, like what I heard you say was empathy. I don't know, just kind of stuck out for me for both sides, right? Like trying to put, as an entrepreneur, try to show value to the to those that are on the research side, and as a researcher, try to understand the value that the business team could bring to the table as well.
Absolutely.
Kate, I know we're down to the last 5 or 6 minutes here. One question for you that I think might be interesting to the audience. For those of us that want to keep our finger on the pulse of digital health, which news outlets do you plug into, and do you recommend that those of us on the audience?
I find so much of what I learn these days actually comes from like my community. The Slack groups that I'm in, where people share something, because there's so much happening and so many interesting news sources, right? It's just really hard to aggregate it all. And what I also love about excuse me, those environments is like people's thoughts on it, right? Because sometimes, like, I'll be honest, like I see a news release about like a company doing something and I'm like, what? Right. And so like when I'm in this, like, whether it's on social media or in one of these Slack communities, right? And someone like, you sort of like, someone else will be like, they'll put a little emoji with like the eye roll. And I'm like, oh, it's not just me. And like, so I really enjoy that aspect of it. It's just super helpful for me. There are a couple folks who have Substack newsletters or Medium, and they're doing sort of deeper dives. And I think that's one of the things a lot of us miss in journalism today is that, we get these short articles because that's what like the newspapers, the news sites provide. But people are really writing these interesting deep dives where they, take apart a sector of the industry. And like, I mean, no surprise, right? Like as someone as nerdy as me, I really enjoy those. Like they'll go out and interview people. I'm trying to think of, Chrissy Farr, who was a journalist and is now a venture capitalist at OMERS, used to do that a lot. And I always found that really helpful when someone, does that for a sector.
Gotcha. Thanks, Kate. And one other thing I wanted to ask you, what's your latest area of focus? What are you currently, I don't know, what are you currently focused on?
Well, it is week 5 of the winter quarter at Kellogg. So my area of focus right now is my students. Teaching a class right now at like the Introduction to Entrepreneurship class at Kellogg. And I find the Kellogg students so inspirational, right? They're just their curiosity and the questions that they ask is really fun. So I'm doing that, and I have a couple early stage startups that I'm working with. One in the women's health space, one in the GI space, and one started in smoking cessation, and really interestingly, like has some of the most impressive engagement statistics in the hardest to reach populations that I have ever seen, called Vincere Health. And I'm like, just really enjoy, when people dig into hard problems and then they're successful at it.
That's great.
Yeah.
Well, Kate, I know we're down to 3 more minutes here. I don't see any other questions out there. If anyone has any other questions that you would like to post, please go ahead and do so, and we can raise them. I know there is one question: is anyone attending Vive in Nashville over the next couple months? I know we're planning on attending. A couple of us from Manifold Group and our incubator company, Lots of Helping Hands. Kate, are you planning on attending Vive?
I'm not going to that one. I'm looking forward to HIMSS. Is coming to Chicago. So that'll be exciting. This Saturday is the Kellogg student-run healthcare conference, the business of healthcare at Kellogg. So I'm looking forward to that. And then Booth has theirs coming up in a couple weeks. So I'm enjoying. I always enjoy when I don't have to get on an airplane to go to a conference. As I look out the window at the snow falling, I understand that others may not want to be here, but
Yeah, got a couple of good ones right down the street.
Yeah,
sounds like.
Yeah, it's great.
Well, I don't see any other questions posting to the chat, so let's see here. Can everyone see the slide on the screen?
Yeah, it's up there.
Okay,
the
Kate,
Slack channel. Speaking of ways
to
learn.
Yep, and I promise I did not ask Kate for an endorsement here, but we have set up at Manifold a Healthcare Pulse Slack community. I know many of you on the webinar today are part of that community. If you're not, we would love to have you join. You can scan the QR code with your phone. You'll also get a copy of this presentation afterwards. So if you don't have the time to get your phone out and make that scan right now, that's okay. But we would love to have you join. And just to wrap up, I just want to say thank you to everyone for attending and participating in the chat, helping spread the word on population health and personalized care. Thank you very much to Dr. Kate Wolin. Kate, thank you so much. I really enjoyed the conversation. I think the audience really enjoyed it as well. You are our first guest for the Healthcare Pulse Speaker Series. The next event will be in March sometime. Date and time and guest to be forthcoming. Check Healthcare Pulse for more information there. And I think that's a wrap. Thank you everyone again for the time. Have a great weekend.
Thanks.
Thanks, Kate.